Thank you so much, everyone. It was a pleasure to moderate this panel. And now I would like to invite Ana Flavia Pires, Director of Germ Shore, who has experience both in the public and the private sector. She will conduct this panel about access, new technologies, and new environments of health. Thank you, Carlos, for having me. Congratulations on the event. This was a very interesting panel, and now it's important to discuss, new technologies and the self-testing. I believe that we will have self-testing in Brazil available very soon. And so now I would like to invite for this next panel, Cassiano Correr from Abra Pharma. And I would like to ask you all to make a quick introduction. And I would like to invite Pablo Moreira, Segundo Leon from Peru, Cesar Cano, and Dr. Elliot Cowan, who is our international speaker on this panel. Cassiano, are you ready? Over to you. Good afternoon, everyone. Can you all see me? Let me share my screen with you then. We can hear and see you very well. I would like you to make a quick introduction about yourself and then move on to your presentation, please. Well, thank you so much for having me. My name is Cassiano Correr. I'm a pharmacist. I'm also a technical consultant for Abra Pharma. I coordinate a program of pharmaceutical assistance. Abra Pharma is the Brazilian Association of Drugstore Chains. And I'm also CEO of Clinicar X, consulting on pharmacies and drugstores. So today I would like to talk about a case and share with you how the COVID testing has been going on in drugstores in Brazil. This is a study that was conducted this year evaluating the results of these tests and how the pharmacies and drugstores are working and offering this type of service to the population, following all the good practices in the health sector.
So first, just to give you an overview, if you're not used to the numbers, Abra Pharma is the Brazilian Association of Drugstore Chains. We have around 8,000 drugstores in all states, and talking specifically for COVID tests, since last year, as soon as Anvisa granted authorization for drugstores to conduct COVID tests, we started offering that service. And so we have more than 4,300 pharmacies providing that service. And last year, we started to monitor these results through a weekly panel. And we have totaled more than almost 12 million tests being conducted since last year. And this weekly dashboard is very interesting because it tells us a little bit about the history of tests being done inside drugstores week after week. We are currently on week 79 of the process, and how this testing curve somehow also follows the pandemic curves, the different waves and the moments of peak of the pandemic, and now in the last few weeks with a gradual reduction in the volume of tests, of course related to the growing vaccination program in Brazil. But I would like to highlight one thing for you here. First, I would like to reinforce the fact that drugstores have followed the evolution in technology of tests in Brazil. Tests are an important tool when it comes to the role of drugstores and the fact that they remained open during the pandemic. We have had 3 generations of COVID tests being offered inside drugstores. A first generation with IgM and IgG antibodies, a second generation of tests with antigen tests, which without a doubt was the most used and most looked for test, and a third generation of more specific antibody tests for anti-spike tests that are being offered in these drugstores, but at a lower demand. So in order to assess the data and conduct a more in-depth study, what Abrapharma did was to collect data from all the tests that were conducted from January to June 2021, and we conducted a retrospective study on the clinical data of such patients. Because all patients, they get a medical record, and the test is part of that medical record. And we conducted a large study with more than 3 million services provided in the first quarter of the years, conducted by more than 8,000 pharmacy professionals in more than 2,600 pharmacies in the chains that are associated to Abrapharma. So this study shows you sort of a clear picture of the disease in Brazil, and it is a scientific study that is being prepared for being published in an international journal since we have such a representative sample. So the role of drugstores in COVID tests has been debated extensively. And for millions of Brazilians, the story was pretty much like this. Once people would wake up or they started feeling certain symptoms, they was unsure, am I with COVID? Do I have COVID or not? What should I do now? And then drugstores became a new place for people to look for medical assistance, a place where they could find a qualified health professional and where they could find an initial or definitive answer to that problem, or especially that anxiety of feeling symptoms during the pandemic. This is an interesting service because it didn't exist before, and it's a service that has been provided to millions of Brazilians from all age groups, men and women, throughout the country. This is a profile of all the services, all the patients that were tested this year. So we are talking about a pretty much 50-50 division between men and women. Adults between 18 to 39 years of age represented almost half the patients that looked for this type of tests in drugstores. After them, adults between 40 and 59, and elderly 60 years of age or older. But in general, drugstores were open to welcome patients from all age groups. Once patients got to the drugstores, in order to explain the service protocol, because it was more than just a test. Every patient, once they got to the drugstore, they were, of course, welcomed, and there was a protocol. And they were able to implement a unique protocol regardless of the region of the country. And even if they are private chains that are competitors among themselves, they were able to implement a single protocol that included an initial step with a clinical triage to identify the symptoms, a second step where the most appropriate test was recommended and conducted, and a third step of the protocol with the official result report and guidance and recommendations for the patient and possible referrals depending on the results. And talking about the specifically about the first part of the protocol, which is the clinic triage, all drugstores implemented a standard anamnesis based on information from the Ministry of Health. Pharmacists would ask a number of pre-designed questions. The answers were included in the software, and we were able to determine the probability of these symptoms being connected to a COVID infection, being connected to a severe respiratory syndrome, or maybe they could indicate that even though that patient had contact with positive cases or had a trip recently, that probably was not the case of a COVID infection. And this structured anamnesis gave us a clear picture of the disease itself. So patients that came to pharmacies or drugstores to do a test, they had cough, a runny nose, a sore throat, and a headache. These were the four most common symptoms reported by patients that are connected to a common flu as well. And also more specific symptoms like loss of a sense of smell or sense of taste that are more related to COVID-19 with a lower frequency of 6.5%. And if we compare the symptomatic cases according to age group, it's interesting to see how these initial symptoms were very similar regardless of the age group. So here in this graph, we see the percentage of patients presenting one symptom in the moment of the test, and on the x-axis, the different symptoms that were reported. And each line, each color, represents a different age group, and they all have very similar symptoms with some small differences, like cough was more common in the elderly group, diarrhea was more common in children. So small differences between age groups, but very similar in general, regardless of the age group. So after the clinical trial, after this initial step of the protocol was applied, we would identify the probability of severity or the level of that case. So after this initial anamnesis, 47% of the patients were possibly not contaminated with COVID, 29% probably had regular flu, 12% had a suspicion case of severe respiratory syndrome. So 1 out of 10 people going to drugstores had symptoms that were severe, that needed a quick referral. And this anamnesis tool was very important to help us identify how severe the case was. And of course, after the test, we were able to send these patients to receive the proper medical treatment. Still looking at the symptoms and the disease profile, it was interesting to notice that, of course, according to the protocol coming from the Ministry of Health and the anamnesis that pharmacists conducted, we had coughing and shortness of breath as the main symptoms that were related to more severe cases or a suspected case of severe respiratory syndrome that were present in 77% or 54% of patients, depending on the symptom, which differentiated this group of patients with patients that were only with a suspicious case of a regular flu. Once this initial anamnesis was conducted, pharmacist was now confident to indicate an antigen test or an antibody test. And the antigen test represented 85% of the total tests that were conducted. And remember, I'm looking only to data from January to June this year. And looking at the positive cases, we have 32.3%, so 1 out of 3 tests were positive in that period, and that's for antibody tests, and for antigen tests, 1 out of every 4 tests were positive, if you look from the period from January to June. So looking at this year specifically, let's remember that we are talking about a predominance of infections caused by the Delta variant. And patients that tested positive with an antigen test conducted in the drugstore, 10% were completely asymptomatic, which in this sample represents hundreds of thousands of people. So we did have people that didn't have any symptoms, but that were tested for some reason and ended up testing positive. Moving forward in the same analysis, if we compare different age groups, let's look at the age groups with the highest prevalence of positive tests for antigen tests. First, elderly, 34.5%. After that, adults between 40 and 59 with 31%. And surprisingly, in third place, adolescents. After that, adults, young adults between 18 and 39 with a slightly lower rate of positivity than adolescents, and then children with only 20% of positive tests. Now looking in more details at the data, we were able to compare the symptoms that and the prevalence of such symptoms depending on the result of the test. After the anamnesis, after the antigen test, I was able to compare positive patients and negative patients and their symptoms in order to try to identify the differences in the clinical manifestation of the disease for those that tested positive for SARS-CoV-2. And it's interesting to notice that fever or loss of the sense of smell and taste, even though these are symptoms that characterize the disease according to the literature, they were not so prevalent. Even among patients that were negative or positive, but even among positive patients, the presence of such symptoms was around 10%, so 1 out of every 10 patients. While the most common symptoms and the most difficult symptoms to really differentiate cases of COVID from common flu, like cough, a runny nose, a sore throat, and a headache, were present both in positive and negative patients, but of course, with a higher prevalence for positive patients. So a more intense clinical manifestation of the symptoms for the patients that tested positive. So when we look at this graph, it becomes clear how important tests are. Even using an algorithm to try to identify the suspected cases without a test to confirm the diagnosis, it's very difficult to identify the disease just based on clinical symptoms, because most likely you will make a lot of mistakes to establish a diagnosis if the patient is positive or negative, or even if you are trying to differentiate more severe to lighter cases. And now, approaching the end of my presentation, I just want to highlight that what used to be unimaginable, thinking about drugstores as a new point of care with clinical characteristics, and using the huge spread of our footprint in the country, and the implementation of a highly complex protocol, the training process that was required, all the quality assurance measures, the use of a standard result report, and using the health surveillance services from all municipalities. Despite of all these barriers, what we had was drugstores working pretty well as these point of care with their open doors, providing the services to millions of people. And these pictures tell the story. They tell the story of this moment of Brazil, which is also an important moment for drugstores. Really remote areas in Brazil where many times we didn't have access. We had pharmacists on boats and traveling to people's homes, pharmacies and drugstores serving as pillars for these communities, and as a place where people were able to find information, a quick test, and the appropriate referral to other services, which contribute to eliminate some of the pressure that was put in the local health systems from all the patients that were looking for these services with symptoms of COVID-19.
So this shows that this program is a reality. We have been working on this area of pharmaceutical assistance for a long time now, and we can see that the COVID test is only the tip of the iceberg of what drugstores are able to do within the healthcare sector. So whether it's regarding adhesion of treatment, self-care, telehealth, quick tests, not only for COVID-19, but other, quick tests that are already conducted in drugstores. There is, regulatory barriers, but we have many tests being conducted in pharmacies, and of course, vaccines. I'm not going to go deep into vaccines, but pharmacies already offer vaccines since 2017. And regarding the pandemic, they could offer their capacity and their facilities to conduct vaccination. Thank you so much again. Thank you so much for having me, and I'm available for questions. Thanks again. Thank you, Cassiano. Stay with us because we will have a Q&A session with all other speakers at the end of the panel. So now I would like to invite Pablo Moreira. We are going to change a little bit the subject. This is a panel about new technologies and new health environment. So we're going to talk about other experiences other than COVID. So now I would like to invite Pablo to give his talk. All right, Pablo, so again, you have 15 minutes. The floor is yours. Thank you so much. Thanks for having me. My name is Pablo Maciel. I'm a pharmacist. I work in the healthcare in Victoria da Conquista. I'm conducting my master's in public health, and I'm going to talk about hemoglobin testing in the healthcare sector. I'm not sure if you're in presentation mode yet, Pablo.
Não tá mesmo. No meu computador.
No, not yet.
Deixa eu só ver se você consegue. Agora sim, agora sim.
Yes, now we have it. No, just 1 second, please.
Tá aparecendo aí?
Can you see my presentation?
Não. Você cancelou a apresentação.
Not yet.
Agora sim. Tá com algum problema na hora de transmitir. Acho que você mandou a apresentação? Não, não mandei. Tá no meu computador. Agora sim. Foi? Pronto.
I'm presenting directly from my computer, and now we're good to go, I believe. So let's do this. Okay.
Bem, então a gente vai trazer pouco da experiência do
So we're going to talk a little bit about the point of care testing of glycosylated hemoglobin. And I'm going to talk about the experience of Victoria da Conquista. We have about 350,000 inhabitants. We are a reference regarding education and health. We have 2 public universities and other 5 private universities with courses in the health area. We have a good level of organization. We have solid partnerships between the universities and the public healthcare sector. And with that, we are able to work together in teaching, research, and other projects in the city. We also focus on the public district pharmacy, which is also a pharmacy for the Federal University, and we have 4 pharmacists working there with a good clinical education. In 2018, the city had 2 projects with external funding. The project Health Rise, funded by Medtronic, and another program from the public healthcare system of Brazil to focus on chronic diseases. So this was the first point to start testing of hemoglobin A1C. So we knew that we had to work on offering testings to control diabetes, for example. And so we discussed the idea of offering to people this hemoglobin test available for people, which is the GO test, both for diagnostics and to monitor diabetes. And we know that how difficult it is for people to have access to laboratory tests due to distance. And so we thought to make this type of test available at the point of care. So why using the point of care at the clinics? We wanted to understand if it was effective and the cost effectiveness of such initiative. So we developed together with our team, we have a partnership between technicians and students from the university, from the pharmacy course of the Federal University of Bahia. And we work together conducting a review study to understand that if investing the resources of the Health Rise project, if that would be cost effective. So we developed a research. The goals was to evaluate the cost effectiveness of the point of care A1C tests in comparison to laboratory tests for people living with diabetes type 2. We used the economic model based on Markov, and we wanted to evaluate the cost effectiveness for the city to evaluate if we could bring this technology to the city to monitor people living with diabetes type 2. Thinking about, prevention of cardiovascular complications, amputations, problems with the kidneys, and so on. So we understood that a better control of glycemia levels would reduce the risk of complications, and the control of A1C would reflect in the control of the disease itself. As a result, we were able to understand that the use of the point of care is a cheap alternative to improve access to A1C tests and resulted in an increased rate of early control of glycemia. So we had the funding from two programs, from the Health Rise project and from our public sector in Brazil. We do not carry any conflicts of interest, and that did not, the funding did not interfere in our routine in the city. So if we have the cost effectiveness of this alternative, how would that work in the community? We had to understand the use of the point of care, and we chose then to observe underserved rural areas. We have a huge city. This is the third largest city in the state of Bahia, and we have rural areas that are almost 100 kilometers away from a laboratory, for example. So we developed the research in these areas, and we wanted to understand if our interventions would be sustainable in the long run. So we trained professional healthcares, especially considering the population with diabetes and hypertension. And so we offer the point of care in 4 communities for A1C tests. So we conducted the before and after tests. We had education interventions, and we also used the results of the A1C tests to help with the interventions in the point of care and other treatments. The study was interrupted. We had prepared 6 months of study, but we had to finish in 5 months because of the pandemic. In 2020, in March, we had to stop our activities, and we have used the results that we had in those 5 previous months. So now we were able to identify that for 17% of the patients, we were able to control diabetes with the point of care with the use of that equipment, and 38% of those had a reduction of over 1% in their A1C levels. With that, we conducted a third study, also funded by the Health Rise program, and we wanted to understand if there was a way to apply the use of A1C tests and other points of care, both in rural and urban areas, or areas with difficult access, communities in the cities that were away from laboratories or healthcare centers. So we wanted to understand if the use of the point of care device was feasible. So the goals of this test was to evaluate the application of the point of care technology to estimate A1C in the glycemia control. We have evaluated a database from 2018 to 2020. So we had different initiatives conducted by the Secretary of Health. And for those who had not recent tests, we made those tests available through the point of care devices. If other people had a suspicion of a change in their level of glycemia, or they had a history in the family, we also made those tests available. As a result, these patients, from 143 patients that did not have tests, they performed the test and they had levels above 7 or 8% if they were adults or seniors. So we were able to identify that the use of the device improved the access to the test for people who live in underserved areas. And we were able to increase the level of diagnostics to identify patients with under-controlled glycemia. With that, we improved other discussions internally. So for example, if we make point-of-care devices available at basic health clinics, where people come back after 2 months to control their glycemia levels, for example, is that an effective initiative to help with the glycemia control of those patients? If we offer quick tests, we can decrease the lines of, appointments, health appointments. And if the patient is already controlled with that type of intervention, so then we started at the pharmacy. We took a part of those patients from our service. So these are patients that have diabetes. They use insulin regularly, and they use the capillary glycemia equipment. So they come back to the pharmacy regularly. We have dosed their AC1 in the pharmacy. We serve all of them. And within the appointments, for those who had not a test, we made the tests available.
And what are the results we have had so far? So overall, we assessed capillary glycemia as well as HbA1c. And when we have a patient, and here I'm talking about patients with postprandial glycemia, we are able to have 21% with glycemia lower than 180, among 180 and 250, 30% of patients, and above 250, 42%, which indicates a level. When we assessed HbA1c, we noticed that out of them, 33% had an HbA1c level lower than 8, 36% between 8 and 10, and 31% of the population in the study initially in this first appointment had an HbA1c level above 10. So 1 out of every 3 patients we saw in our drugstores that are on insulin do not have their diabetes under control. With this data, we can demonstrate that HbA1c in the point of care allows us to have a fast assessment of patients. We can identify patients that are not controlling their glycemia, and we can refer them to non-pharmacological interventions that are conducted here, but we can help adjust their insulin dose. So if we think that 1/3 of the population doesn't have their glycemia under control, we should also discuss that if HbA1c should be the gold standard for monitoring the patients. Maybe we can have a protocol that use pharmacists and the healthcare professionals so we can make interventions that are more effective to control diabetes of these patients. These are the preliminary results. We will continue to see these patients in 3, 6, 9, and 12 months, and we will assess the HbA1c results from these patients and the behavior of these tests. This will be the next step of our process. But what are the challenges that we have identified for the process? Dr. Cassiano already mentioned the challenge regarding regulation. I think Brazil needed to move forward so we would have the legal safety to conduct investments on point-of-care tests for A1C and for other parameters. For primary care, we need to ensure we have the right resources to acquire the different materials we need connected to HbA1c, but in the first semester of 2022, we will include a lipidic profile, and we are considering the possibility of including other tests that are important to assess, especially the effectiveness of the drug treatment, the drug that is collected here in our drugstore. And we have to think about point-of-care tests in combination with the different lines of care, especially for chronic disease like hypertension, diabetes, and cardiovascular diseases. So the technology that is offered is not only a result, oh, your HbA1c is at this level, but what is going to happen after the result of a fast test so they can truly gain control of their disease and gain more quality of life. And we also need to discuss the awareness of health professionals. There's still a long discussion about the quality of these results. In our case, before we start our activities here in the rural areas and in our drugstores, we did an internal assessment of the device that we use. We use an Abbott device for this purpose, but we chose to use 2 pieces of device. We started with one from Roche. Today we use one from Abbott, but we also need to understand that when we are making the investment, what are the internal evaluations that these devices have? We did an internal validation as well of this process, but we also need to raise awareness among professionals, especially the ones that left college longer. It's important for them to understand that these results are comparable to results coming from a lab. The great difference when it comes to point-of-care tests is the fact that we get an immediate result and patients can leave that appointment with all the necessary recommendations without the need for patients to go to the lab, which takes more time, it's more costly. And when it comes to the public health system, it crowds the service. Our perspectives for the city for 2022 is to maintain the use of point-of-care tests for HbA1c. We are currently acquiring new tests, and in 2022, we will include a lipidic panel as well. And we will work on the results depending on what we find in our assessments. Maybe we will include a higher number of drugstores and pharmacists so they can use the technology to ensure the treatment is being properly conducted, so these people can have more quality of life, reduce the level of complications, and they generate fewer costs to the health services. This is my contact information, and I'm available if you have questions. Thank you. This has been a great talk. I hope we have time to talk about it in the end. Now, I would like to invite Dr. Leon to talk about his experience in the use of point-of-care tests. It's a pleasure. Thank you for the invitation. Maybe we can show my presentation.
Ok, perfecto. Bueno, vamos a conversar ahora un poco la experiencia que hemos tenido en el Perú haciendo investigación respecto a pruebas rápidas para COVID.
Let's talk about the experience we have had when it comes to fat tests, rapid tests, and the perspective of COVID-19 in terms of diagnosis. Next one, please. We have a problem. And the problem we have, and it's not a medical problem. And the biomedic approach we have in the beginning of the pandemic, this became a problem that is beyond of what we had imagined initially. We are no longer talking about the SARS-CoV-2 infection, but a problem that is a social problem. One of the largest problems we have had in the history of mankind. Next one, please. For us, working in labs, so we can explain to other professionals what diagnosis depends on. We have a number of tools that we can base our diagnosis. We have molecular tests, and many countries base their lab diagnosis for this infection, for COVID-19, in serological tests, antigen tests. And this was a mistake because we had a result weeks after the person had been infected. So moving to a molecular test was a difficult step for many reasons, especially because the world didn't have these tests available. So little by little, they started to see this and implement this with the help of centers to control the diseases in China, the OMS, and other countries started to use molecular tests. The antigen test was a good evolution. We heard a lot about this today, and it became an important tool for us that don't have such difficulty in implementation, but especially the problems that countries were not ready for that. They were not ready to use molecular tests in an efficient way. So if you look at the global scenario, where was the largest amount of tests coming from? We can realize that almost 50% of the tests were coming from Asia. Some were manufactured in other regions of the world, but Asia was the main supplier of these tests. In that sense, many of the tests that were being marketed and that are still available are serological tests. And then we started with molecular tests. They started to grow in the different countries. Countries started to have more access to them because they had molecular laboratories inside universities and private and public health systems. However, that was not a reality and still not is in some countries that centralized their molecular testing to detect COVID-19 cases. So if we look at what happened in Peru up until a few days ago, and we have an open data policy, we processed a lot of rapid tests. In the beginning, Peru was one of the countries that used the most rapid tests, especially serological tests that were bought in high quantity in the country, especially in Lima, where 30% of the Peruvian population lives. Lima was the city with the highest presence of these tests. So there was a level of positivity that was around 11%. So in terms of expenses, the fact that we acquired these lab tests that before the pandemic was not part of the budget, up until the moment, they represented 300 million Peruvian soles. This is what it is important to see these numbers in the official government webpage, because these resources represented 30% of the tests. And 30% was for fast, rapid tests. It's not that when we look at the details, they are not represented here on the slide, but the highest investment was made to acquire rapid serological tests. But when we see that serological tests that were acquired, especially recently, are related to companies that distribute devices, probably 30% of these expenses is focused on those type of tests, and other 30% to open technology tests that were more centralized when it comes to the work of the Ministry of Health. So during the pandemic, and that was a reality for many countries, we had a need, and we still do, not just in Peru, but many countries, which is the need to have a fast diagnosis, because patients need that. And this is a very important point. We are talking about a respiratory infection. What we do not want is for patients to go to the hospitals. And this is what happened in many places. And tests, they need to be easy to be interpreted when patients need it, and with materials that are easily accessible and easily used. And we need that fast implementation at all levels, but it's important for them to have the highest standards of safety with very little training required, so everyone can use them. So if we look at lab diagnosis, in the past 2 years, we were able to see that this was actually information that we already knew, but the population wasn't aware of, which is the fact that an effective diagnosis was basically the eyes and ears of our global response to the pandemic. So without a diagnosis, it's almost like we are blind and deaf in the face of an event that is affecting the whole planet. This graph shows us what happened in Peru in the past few months. And this was the scenario regarding the number of tests that were authorized by our regulatory agency. Let's wait a minute. We have a technical problem. We'll make a quick break and we will be right back.
Bien, les estaba diciendo que en el Perú.
Okay, so we're back. So in Peru, during the pandemic, the agency regulating medications also authorized 700 laboratory tests. When we see this table here, of all those tests, 617 were IgM and IgG tests, antibody tests. This is the official information for PCR tests. So the largest amount of tests actually was authorized for serological tests, and we understood that does not solve the problem of isolation, which is a very important piece of information so that more people do not get contaminated. These results come from molecular tests. We were then trying to find out a solution. One of the things that we wanted to see was the idea to break the centralization regarding laboratory tests. They are conducted in large laboratories with a lot of requirements, very skilled people, and with high levels of quality. So the idea was to move out of the scenario without losing quality and transferring the laboratory tests to the places where patients were. With that, we evaluated a test, a real-time PCR test that takes about 45 minutes between sampling and having the results. So there was a reduced workflow, and this is something that can be used with the patient and detects both genes RDRP and N, which are the regular tests that were being conducted throughout the country. This new validated technology is a biochip technology. It allows us to process 4 samples in one run, each one taking 45 minutes, which has negative and positive controls included. So you get 10 microliters and mix it with the fluids inserted with the chip. That is amplified within a very small device, and this provides you a real-time PCR result in 45 minutes. So this clinical validation is basically conducted through a process of implementation. So ViralLab provided us the reagents and the technology. So this product came from Korea. At our university, we started to develop protocols, training of the staff, and the integrated staff, or the staff was made out of several physicians, the physicians that are on our screen now. And so we conducted several actions to guarantee the training. So the idea was to train the staff to collect samples and also to process the tests of those patients, symptomatic patients that already were at the emergency area of the hospital. So training took about 1 week, and at the hospital we had a sort of a booth. But that type of equipment could be used out of the booth. So everything happens inside the device, really. So we were able to evaluate 64 patients, symptomatic patients who were sick, presented fever, cough, all the symptoms related to COVID-19, and who showed up at the ER. We used duplicate swabs. One was sent to the hospital, the other to a reference lab. Everything was conducted from August to November 2020. So we worked together with the pathology lab from the hospital. One of the important results that we had is that we found a very high sensibility, 100%, 98%, and it works both when the person has symptoms and while the patient is waiting for the results. I can isolate without having to move home or an isolation place. In general, what we've seen is that there were several tests available. We have seen over 700 tests, but not all of them were useful for the pandemic. One of the things that we really need is that the implementation of tests is conducted with more agility, and we need a trained staff. The tests are important, but they have to move from hospitals and ERs and go to local clinics. And what we've learned is the collaboration between university and other areas. This is very important. I would like to thank my whole team of research. Thank you so much. So, Professor Cesar Cano, the floor is yours, and you have 15 minutes.
Bien. Buenas tardes, ¿me escuchan?
Boa tarde, escutamos.
¿Qué tal? Buenas
Good
tardes.
afternoon. First of all, I would like to thank you for having me. I'm Cesar Cano Candiotti. I'm a doctor specialist in occupational health. I'm the vice president of the Peruvian Society of Occupational Health, and it's an honor to be here. First of all, this is my conflict of interest.
Y el tema que les traigo es un poco para poder conversar y compartir la experiencia del uso.
So now we are going to talk about the experience of use of these point of care tests in work settings. So I would like to remind you that what is the importance of occupational health? So we're going to focus on two fundamental rights that sometimes in the medical school you only talk about health, how to reach the highest level of health, but that's not the same at work. We focus on these two rights. It's no surprise that if I'm healthy, I have a ability to work. And if I have good work, I have access to a good healthcare system. What does that mean? With the pandemic, we've seen that several diseases related to work are responsible for 25% of the load. We have 2.78 million deaths per year related to work. And so this is very important. In 2019 was a very important year for us. We had a report from the future of work, and this is a picture showing an automated process. There is no employee here, and this is no science fiction movie. So we were talking about virtualization of work, technology of information technology, and artificial intelligence who would replace the workforce. We were also talking about demography, sustainable development, the impact of climate change, and the changes happening in the workplace. This is a report from 28th of April 2019. And in 2020, we've seen the first cases of COVID. So we had a group of employees that were going home for quarantine. And so we had to start working from home. But there was a group of essential workers that had to keep on going to work. So there were strict measures so that they could still keep on working. So our objectives is to review the principles of vigilance of health, surveillance of health of workers, and the impact of the use of point-of-care tests. So there are some figures here. We've had 266 million people infected. 50% of the workforce of the world, and it's the same in Peru. So we have 2,243,000 infected. So our approach to the workforce is very important. So how did COVID affect the workforce? Let's focus on 4 points. So let's talk about the conditions of work. We've had the healthcare workers who were most affected. There were the risks regarding biologic control, psychosocial risks, how to perform surveillance, and the impact on productivity. We've had an increase on the absence. We've had the costs of hospitalization that could reach up to 15 days, sometimes a month if the patients were placed in a intensive care unit. So we've seen that regarding COVID-19, this is a highly transmissible virus. The detection of the virus takes about 1 to 3 days. There is a high percentage of 40 to 50% of asymptomatic cases that still spread the virus. Why is this important for the work environment? When we look at work environment, we have to reduce the transmission in the workplace, because asymptomatic people, as we've seen from reports, we've seen that COVID-19 pandemic is not the first pandemic we've faced. We've seen the H1N1, and the WHO had already stipulated the phases of work. So mitigation, contention, monitoring, all of it was related. So we had epidemiologic monitoring, education and communication control measures, supply chain, and the epidemiologic surveillance in the workplace. I would like also to talk about the measures implemented not only in the workplace, but also in communities to reduce transmission of the SARS-CoV-2, which is the Swiss cheese respiratory virus defense. It's a very simple model. Each slice may pose a failure in the process towards the objective. So to reduce an event, we would have to work on each slices of the cheese. And so the idea is not only a measure to reduce the transmission, it has not to do only with tests and hand hygiene, but everything altogether.
So the different areas of intervention that we have has to do with the working conditions, health surveillance, focused on the health condition of workers, individually and collective. We do emergency service in some places, and we do intervention in communities and the promotion of health. And let's remember that because of the pandemic, we also identified that not all workers were affected in the same way. There was a group of workers that were at a higher risk, who suffered from chronic disease, and they were more effective from the pandemic. And we see in the different work environments also workers that are not symptomatic. So we did an active search for cases with a focus on early detective. Of course, we made sure we were using high specificity tests that were not invasive and that provided with a fast result. So once we are aware of all those characteristics, we saw that the point of care testing are very important for our study. Here from Dr. Castanho, a study on POCTs from the past few years. These are tests that started in the 1980s or 90s, so they're nothing new. But of course, during the pandemic, they became an opportunity. And they talk about 5 levels in this study. A self-test, the community level. They talk about low complexity medical centers, labs, and hospitals. And in the work environment, we can be in levels 1, 2, or 3, depending on the type of project we have in place. And how is the implementation of the point of care tests in the work environment? We had already mentioned that we do health surveillance with an active search, especially the search of certain infections like tuberculosis, HIV, influenza, and we also use this test for biological control, for toxicological dosage, with markers and urine tests. These are tests that we use for health surveillance work in the work environment and for urgency or emergency treatment as well. We want to have tests for glucose and urine, but these tests can also be used for the promotion of health. And of course, that depends on the context of the project. Some, for example, for the mining context, in remote areas, these are projects that require us to reach workers through a helicopter, and any unusual event requires us to make a fast decision. So to make these type of decisions, we need these tests that will assist us in the process. And how did we implement epidemiological surveillance in the work environment? Talking about that 4 steps that I mentioned before, the planning, mitigation, containment, and recovery. We'd say that these patients, they would go directly to the health system. And what we did was to track all the different contacts that they have, the cases, and the ones that are diagnosed. These cases are interesting because we need to reincorporate those workers in the workforce. But what we do is to do a health surveillance work in the non-symptomatic patients. And to manage symptomatic patients, we need to identify the community load, which is essential. Many of the studies that we conduct, we focus on identifying how effective these tests are for symptomatic patients, but that work is not done for non-symptomatic patients. That's why it can be confusing in selecting the right test. We do just a triage. We don't do a diagnosis when we do health surveillance in the work environment. We use other epidemiological tools, like, for example, some companies, some mining companies, we would do a project for 15 days, and when they came back, we would see if there were any problems. Epidemiological indicators were essential. These are the key metrics that we used regarding new cases for every 100,000 inhabitants. And how were these tests used in the work environment? I'm not going to go into details about the detection methods, but basically we have three types, basically. We can use genetic material, we can use an antigen test, and we can use an antibody test that are generated after a previous exposure, as it has been described here. This was an option that was used in the beginning, but it didn't make sense because we know that serological tests, they identify a case only in the second week, and our concern in the work environment is transmission. So when we look at the behavior of the tests regarding the natural history of COVID, we have the onset of symptoms, but one of the characteristics of this virus is that it can be transmitted 1 to 3 days prior to the onset of symptoms. So at this stage, workers are not symptomatic, and in the worst case scenario, symptoms only appear later. So we see the viral load here. We start that rising before the symptoms, and it goes down up until day 7. The PCR tests do very well in this context. And these levels can stay high after 10 or 14 days. So we can find remaining parts of the virus. And for us, that was also important because some workers would spend 14, 15 days and would still test positive on a PCR test. So we worked with RCT to identify those people. And the serological test, we see this increase after week number 2. This is an important chart because we see that symptomatic patients, they do spread the disease, but in a lower period of time, shorter period of time, sorry. So it's important to identify them earlier on so we can conduct the treatment appropriately. This is what I said before, the studies that we had on sensibility and specificity with a higher focus on symptomatic patients, which are quite established now, but very few studies for non-symptomatic patients. This is the algorithm that we used for conducting antigen tests in non-symptomatic patients, and the confirmation with an acid amplification test. This is the final review from the American College of Medicine, and they proposed a control framework through antigen testing. But let's remember, antigen tests alone are not enough. They need to be part of an epidemiological surveillance program. And this is the key message here. This is a study with a sample of around 3,400 people, and they are correlated to the specificity and sensibility of symptomatic patients in the PCR tests, and specificity for 100%, sensibility of 64%, and for non-symptomatic patients, the sensibility is 35.8 and specificity 99.8. But there is a good positive correlation with a CT lower than 25, which allows us to easily identify patients that are transmitting the disease. But when we do a viral sample, the asymptomatic sensibility can reach 78%, and the symptomatic sensibility can reach 92%, which brings us an advantage in identifying this group that is spreading the disease. So we created this program using an antigen test, but trying to control the variables and especially the epidemiological indicators, how to collect the sample, how to interpret the results. And definitely, tests are not for all workers. We use a technique to identify the different group of workers that will receive the test. The test will be conducted in patients that have a higher risk of exposures, patients that travel, patients that are working in crowded places, and workers that have a special health condition that could cause a complication. And interpretation is important. Let's remember that the community load is important. And in a high epidemiological setting, if the antigen result is positive for a symptomatic population, this can change as epidemiological indicators go down. So the use of tests need to be done within a context. Some studies use these indicators, and the same program includes self-diagnosis, diagnostic tests, as previously discussed. These are tests that are part of a program. So workers, they do the tests themselves, they notify someone, and they do a preventive isolation or an early isolation so the virus doesn't spread. And within a vaccination context, we have to remember that even after 2 vaccine doses, we cannot make sure that that person won't be infected. We decrease the level of mortality and the level of severe cases. But this is a key message. We see that happening in Peru. Vaccines are not the only measure we need to take. There are studies on the value, the predictive value of contamination happening after the vaccine, because that depends on everyone's individual immunological response. So how can we use this type of tests for an epidemiological surveillance work for asymptomatic, symptomatic patients and patients with a diagnosis? Now, some final conclusions. These tests, they should be used within a context of medical criteria and epidemiological surveillance. The tests by themselves don't tell us much. We need to have them in context. A negative test does not eliminate the fact of that patient being contaminated or not. And tests alone are not enough to prevent contamination. Some messages on epidemiological surveillance, labor triage, interpretation. And this is part of the references I have used, and I would like to leave you with this nice picture. And thank you for the invitation, and have a great remaining of the event. Thank you very much.
Olá,
Hello.
estamos prontos. Está ouvindo? Elliot, você ouve a gente?
Yes, just
Ok.
let me see. There we go.
Ok.
Good. Thank you, and thank you for the opportunity to speak to you today. Also, thank you to the translators who are making it possible for me to speak in English. Just a brief bit of background on me. I had a 20-year career at the US FDA. regulating diagnostics, in vitro diagnostics. And I retired about 8.5 years ago. And now I'm doing consulting work, helping companies and developers move their products through primarily the FDA. What I'm going to talk about is very complementary to Marcela's talk from Anvisa. I'm going to give a talk having to do with the FDA, though, and the impact of the pandemic on the FDA and FDA's response to that. So this is what I'm planning on covering. I'm going to talk to you about emergency use authorizations and how they function as a way to provide access to innovative diagnostics during a public health emergency. I'm going to talk to you about some of the realities that have come about that need to be dealt with. There is long-lasting, I think, there are long-lasting implications for the future of IVD regulation, certainly in the US, and I would imagine elsewhere as well. I'll touch on that. And then talk just a short time about how innovative technologies will get noticed by the FDA, since that is indeed the theme for this particular section of the meeting. First of all, EUA, emergency use authorizations. What it's not a permanent marking authorization, but rather it's a streamlined regulatory approach to make new and essential products, medical products, available during a public health emergency. Now, when I use the word streamlined, that has two implications. Number one, the studies that need to be performed to support emergency use are going to be much more limited compared to a permanent marketing authorization. And also the quality management system that's in place. There are limitations on that. So a full quality management system is not actually necessary, which is different from the way the WHO has handled the test for the pandemic, as well as some other countries. So there are just some specific elements that need to be in place, not a full quality management system. So let me take you through the process for a moment here. It begins with the declaration of a public health emergency by the Secretary of Health and Human Services, equivalent to the Minister of Health in most countries. A company would then put together what's called a pre-EUA submission, which is an opportunity for FDA and the manufacturer, test developer, to interact and come up with some mutually acceptable ways to move forward. That leads to the full EUA submission, which FDA then reviews. There's more interaction, and the goal is an emergency use authorization, such that the product can be marketed while the emergency is in place. The idea is that FDA can, because of the limitations on the submission, FDA can respond in days or weeks instead of months. I will tell you right now, something I'm going to talk about in a few minutes, is that this is the ideal, and it was the way that it took place at the beginning of the pandemic, and things have, shall we say, changed dramatically. I will show you what I mean by that in just a few minutes. But first, let me talk about how FDA has communicated and streamlined a little bit more about streamlining the process. So one of the main things that FDA did was they put together templates for emergency use authorizations. And these templates had in them exact wording that FDA wanted to see in such things as the intended use, and in terms of describing what the product is and how it works and that sort of thing. So it was a matter of the sponsor filling in the blanks in this template. I'm just showing you a template from the first paragraph. Obviously, it's much more extensive than this. It also explained in great detail what types of studies are needed, or what types of studies FDA expects for an emergency use authorization in terms of the analytical studies, and that includes limit of detection. It includes inclusivity studies to show that all of the then circulating strains of the virus are detected, and also included details on the clinical performance studies that are needed. There are a number of these templates. Most recently, they were updated on November the 9th, so just about a month ago. I'm showing you here the template for developers of home use tests. There are other templates available for antigen tests for professional use, and for serial testing and screening claims, for molecular tests and molecular home specimen collection devices in which the specimen is collected by the individual and then sent to a laboratory for testing. The studies that are done need to make, clinical studies that are done need to make use of people who, of users who are expected, the intended users who will be expected to use the test. So for example, home use tests need to be supported by data, which shows that people, and ordinary people who would just purchase this from a pharmacy or wherever, would be able to use this test and to show what the expected performance would be by those users. There are many tests that are available, which are for use by professional laboratories, but there are other tests as well that are authorized for use in a point of care setting. And so again, all the studies that are done need to have be done using the intended users to get an idea of what the expected performance is going to be. Just one word about serial testing that I have here. What that means is when you go to purchase a test, you would test, it includes 2 swabs. So you would test once and then wait a couple of days, 2 to 3 days, and test yourself again if the first test was negative. And then FDA allowed performance to be based on that second test. So if it missed the first time and identified as a positive specimen the second time, then the comparator test or the reference test, which is a PCR test, was positive on the first go round. Then the second result for the antigen test could be used to increase the expected performance. A little bit more on transparency. FDA has had a number of, at first they were weekly virtual town hall meetings, it was open to anyone around the world to call in, but now it's actually web-based. So that FDA could not only share its latest thinking, but also it gave the opportunity, or gives the opportunity, for people to ask questions of the FDA and to get answers on the spot. They also established a mailbox, which is referred to as the templates email address. I show that here. And on several of the slides, I have some links that you can follow if you like for more information on any of the topics that I'm going to be discussing. So the templates email address can be used for general questions so that FDA can clarify its thinking on particular subjects. There have been about 70 or 80, I believe, virtual town hall meetings. They're now down to every couple of weeks instead of every week, but they've been important in having FDA explain its thinking on various topics related to the pandemic. So where are we now? As of last week, FDA has given an emergency use authorization of 423 tests altogether, tests and sample devices. 293 of those are molecular tests and sample collection devices for them. 66 of those can be used with home collected samples. There is one molecular prescription at-home test. So a physician or a healthcare provider would order the test, and that means you could purchase it through that prescription. But there are also 3 over-the-counter molecular tests, as well as 11 over-the-counter antigen tests. By over-the-counter, I mean anyone can purchase it from wherever it is being sold. There is no restriction. There are 90 tests for antibodies, and let's see, and I talked about serial screening. There are 20 antigen tests and 9 molecular tests that are for intended for use in serial screening. I'm sorry, 40 antigen tests altogether that have been authorized. FDA has recently, as of just a couple of weeks ago, revised its policy for testing for COVID tests. And in this document, it talks about its current priorities. And the whole theme around this is increased access. So FDA became overwhelmed by the number of submissions it received, and it wasn't possible for them to give every submission a full review. So what it did was it said what was needed, what type of test they would pay attention to, basically, and that is any test that increases access. So that would be home use testing, self-testing. That would also include point of care tests. And also, their FDA for the first time had talked about capacity for manufacturing, so that they're expecting that a test be able to be manufactured at a rate of 500,000 tests per week or 2 million tests per month. If a test falls short of that, or if a manufacturer can't support that, then they won't receive priority review, and unlikely that they will get to move through the system. So it's worth reading this this guidance document. And but again, the theme here is trying to make testing available to as many people as possible. So now let me talk about some challenges to the regulatory process. Something I just mentioned is there was a backlog. That backlog was at one time up to 3,000 applications that were sitting at the agency that were waiting to be reviewed. And FDA's response to that was to bring in all of its review staff from divisions that didn't ordinarily look at infectious disease diagnostics. Rather, you had, of course, the main group, the infectious disease group, took the brunt of this. But different divisions such as immunology tests and chemistry, the chemistry folks were all brought in to start reviewing the COVID tests. And so it was impossible to keep up, but so they did hire another 40 reviewers. The problem was that reviewers don't become reviewers immediately. It takes time. It takes some work to develop a sense for what is appropriate in a regulatory sense. So, but at the same time, FDA was faced with inconsistency among the reviewers. Some were too stringent, some were not stringent enough, and so there was this inconsistency within FDA's reviewing. The other piece was that with everyone working on this at the FDA, they were working literally 7 days a week and 16 to 20 hours a day, just to try to work their way through this. And as a result, there were a number of veteran reviewers at the FDA who ended up retiring because it was just too much for them to handle. So there were new reviewers were hired, but at the same time, there was a loss of veteran reviewers who had that strong sense of what's needed to conduct the review. Antibody tests have been mentioned. FDA is having somewhat of a difficult time with antibody tests. They have authorized some. They will not, they said, authorize at this time, will not authorize antibody tests that are for home use or for self-testing, because it's unclear how much antibody allows you to say that you are protected. Those studies are apparently underway in several laboratories, but FDA does have that concern that someone is going to say, this test is positive for antibodies, therefore I'm protected and I don't have to go through any of the measures that I need to protect myself and others. There have also been a few recalls of authorized products having to do with false positive test results. This affected a couple of tests, and but I think it underlines the speed with which review is taking place and with which manufacturing is taking place as well. Variants. We all know that Omicron is with us, and there are a number of other mutations. FDA has published a guidance, which I'm showing you here, which talks about what manufacturers are expected to do to keep up with this. It was just on Friday, I believe, that FDA published a document which noted that 26 of the molecular tests that have been authorized will miss the virus by one set of primers. Fortunately, there are multiple sets of primers in those tests, and so detection of Omicron would be detected by those tests. But it again underlines the point about having to keep up with mutations and having the manufacturers demonstrate that they're able to detect those new mutations. So, what's the current state of FDA regulation? The reviewers that were brought in originally to help with the caseload, they've returned to their divisions, and of course there were a number of submissions that were waiting for them that companies had turned in before the pandemic hit, and so they are working to address those submissions. But the infectious disease folks are still addressing massive numbers of submissions, even with the added staff. There continue to be 160 new submissions every month. So it's been very challenging for them. As a result, FDA has said they will not accept any pre-submission meetings for a test which doesn't have to do with COVID until possibly the second quarter of next year. Pre-submission meetings are important because developers and manufacturers will meet with the agency to get feedback from the agency on studies and other aspects of their device. And then for novel technologies, there are some options, including the Breakthrough Device Program, the Safer Technology Program. And for those, it's very important for manufacturers to focus on the benefits and the risks of new technologies. And just on the subject of new technologies, it's been interesting because we've seen a dramatic increase in the number of new companies, usually spin-offs from academic institutions, who are developing tests using very interesting technologies such as CRISPR, and trying to get them through the EUA process. But that's also created some issues because the folks in the startups coming out of academia don't quite understand all the controls that still need to be in place for clinical use. There is a program called the Rapid Acceleration of Diagnostics program, or RADx, that you may have heard of. RADx will basically take promising new technologies and work with these companies to fund the studies, as well as interact with the FDA to move them through the regulatory the development and regulatory process. And I show you here a link to that if you're interested. And then last slide is the impact on FDA IVD regulation in general going forward. So I have a lot of question marks here because nothing's definite, of course. But in terms of what's coming sooner rather than later, we can certainly expect that continued delays as FDA tries to catch up on previous regulatory submissions or move other submissions through the process in the case of the infectious disease diagnostic people. Some things that will happen, I think, later rather than sooner. It's possible there will be a more efficient regulatory review process coming, just because that's been demonstrated, the effectiveness of templates. So that concept may be applied more frequently, and that will help with test developers and manufacturers. And then, of course, FDA may be more accepting of over-the-counter tests or self-tests. This is, it's interesting that they moved to self-test, and there's a lot of pressure politically for them to do that. But up until now, the only test that has been approved for self-testing since 2012 has been the HIV over-the-counter test. So now, as I mentioned, there are a number of over-the-counter tests available for COVID. And then there's also the hope, of course, that the experience that FDA has had as a result of this will have them be better prepared for whatever is coming next in the way of an infectious disease. So I think that is all I have. Thank you very much for your attention, and looking forward to the question and answer period. Thank you.
Obrigada. A gente vai dar continuidade.
Thank you very much. We will continue now, invite our next speaker, and in the end, we will open for questions.